SHAKIR Bakkari topic is optimizing IBD therapy. So, SHAKIR.
Good morning, everybody. Thanks for organizing committee for inviting me for this nice, wonderful meeting. Thanks for nice introduction. So we'll start our talk. Our talk today is talking optimization of IBD therapy, how to optimize IBD therapy. So first of all, I ask the question, do we need to have optimization of IBD therapy? Yes, of course, we need to have optimize our medication because we have heterogeneity of IBDs. We have good number of patients with non-responder, primary non-responder. We have good number of patients as well as a secondary loss of response. And we have a disease that change over time. And we have a patient that change over time as well. So one size does not fit all. So you need to have actually deciding your patient, deciding your, or based on the phenotype of disease and based on the patient preference, patient disease pattern as well. Where do you want to be? What our target? Optimize the dose of therapy. Actually, we need to have the right time. Right time means not too early or not too late, and earlier is better than late. And understanding the prognosis of disease is a matter as actually. We need to have a right dose. We need to have the right dose, that not too early and not too much. We need to have a right interval, no big throw between the doses. And we need to have the right duration, not too short and not too long as well. And we need to have the right efficacy, safety, adverse effect. There is no adverse effect of disease control. And at the end, we need to have a right cost. So this is our aim. How to optimize, or our aim to optimize the medication. I know it's a bit tough, sometimes a bit difficult. It's not sometimes, most of the time it's a bit difficult, but this is our ideal goal to achieve it. The questions why we are not there yet. We have the classification, existing classification of disease is not enough to direct our therapy. We didn't have a classification yet that decide which type of phenotype, choosing what type of drugs you will choose. So we are not there yet. The goal of our treatment is not wrong, but it's different now. Initially we're looking for clinical symptoms relief, and now we are looking for the mucosal healing. Now we are looking for in the near future, we are looking for histological remission. And then probably in the future, we are looking for the cure. So our target is different from time to time. Therapies did not work. We know that. And there is disconnection between the patient and healthcare providers. Therapies did not work probably because of interpatient variation. Mechanism is not work. Wrong dose or misunderstanding of the pharmacokinetic and for the drugs, and lack of patient adherence. Disconnection because we didn't have a good communication between us and our patients. We have different expectation. Probably the expectation of yours is different from the expectation of the patient. He needs a quality of life to enjoy his life. And you are looking probably for mucosal healing, you are looking for clinical response, and that's different. So actually you did a good job in the progress of disease from classification, from phenotype, from therapies, but I think we are not enough yet. This is not enough. We are not there to decide or to achieve what you are planning to do. So from the histories, we look for the phenotype of disease, location, behavior, age of the disease, age of the onset, a prognostic indicator. we try to understand genetic. We observe the families, genetics among the affected families, and we look for the genome studies, as well as to study the diet, what the role of the environmental factors in IBD, what the role of the microbiome in IBD, what the role of, or what the other factors that can play a role or can trigger the IBD flare-up. We know the disease has a poor outcome. So we initially, from the history, we base our medication or our treatment based on the small trials, based on short outcome, we adopt our management and medication from other diseases like rheumatology or psoriasis. So we adopt this treatment from other diseases. We did initially step up approach. We start to be step up and then step down approach. We look for the quality of care, and now we are looking for actually treat to target strategy, and this is a new thing. We start to do it. So our aim actually, or at the end, we're looking for the subtype of disease that define the treatment option. We need to have a drug that's effective, sustain, safe, and cure of some patients. We know there are factors that influence disease control. We have a disease factor, we have therapy factors, and we have patient factors. Disease factor, we have a really bad or good factors, or really I saw it in our clinical practice. We have a good lag between the diagnosis and disease itself. We have a phenotype and genotype and microbiome and immunology. Therapies factors, resection. We know the resection, if you have a first resection, this patient he has high risk to have a second resection. Prior failed therapy, steroid, dose response, half-life, and delivery. We have patient factors. BMI, obese patient maybe have a poor response to anti-TNF. Gender, being male, is a bad factor to response, or an indicator that you will not respond to the anti-TNF. Nutritional status, pharmacogenomic of the drugs, adherence and smoking factor as well. We have a clinical predictor, disabling of Crohn's disease. 3 factors we know: that's steroid, age of the diagnosis below the age of 40, and renal disease. So now choose our outcome to measure the treatment to target symptom, growth development, lab values, and mucosal healing threshold, and we have a good valid indices that indicate a mucosal healing and surrogate marker. This is treat to target strategy. Was talking yesterday about Dr. Nahla speak about it. So this is a proposal of, I will not go through it because it's what discussed yesterday. We need how to optimize the therapies of IBD. Specific approach therapies, 5 say maximize the dose and deliveries. Delivery may be impaired in distal colitis. That's why you need to add topical therapy as well, and the dose of medication. Steroid, we don't want to be used long, so not too long. Don't offer treated the patient with steroid. Thioperin, you may add allopurinol in some cases in patients with a side effect who has side effect of mainly azathioprine, and you reduce the dose and you add the thioperin. Add allopurinol. Anti-TNF therapeutic drug monitoring. That's what I will. Next slide will be speak about anti-TNF and therapeutic drug monitoring. So this is a biological therapy we know for IBD. TNF inhibitors, adalimumab, certolizumab, infliximab. For ulcerative colitis, we have adalimumab and golimumab, infliximab. Cytokine inhibitors, we have ustekinumab, and we have also for Crohn's disease, and now is ustekinumab approved in European countries for ulcerative colitis as well. Selective adhesion molecules, natalizumab and vedolizumab, and ulcerative colitis for vedolizumab. This is a definition of a primary non-responders, or a definition to assess how to assess the response. You have a primary non-response and you have a secondary loss of response. So primary non-responder individual who failed to respond after initial induction within 12 weeks. Secondary loss of response, who failed after, or initially he did very well and he responded, but he failed while he is in maintenance. We know the incidence of primary non-response about 10 to 30%, and the incidence of secondary loss of response about 50%. This is the AGA guidelines regarding talking about the maintenance of how to monitor anti-TNF or mainly anti-TNF for during the loss of response or secondary loss of response. So if we have active, you have a reactive and you have a proactive. Reactive means that if a patient he did well or he's doing well during the maintenance and he lost of response, then you react to the anti-TNF or what you could to react to the drug. Quiescent, if patient is doing well, and you plan to do proactive therapeutic drug monitoring. Therapeutic drug monitoring with the integrin inhibitors and interleukins, we don't have data yet. And in induction, there is no clear guidelines for during induction. So what do you mean by reactive therapeutic drug monitoring? So therapeutic drug monitoring, this is really actually prospective, retrospective study for infliximab. Treated base who's looking for the drugs and antibodies, actually published in 2010. Actually, we did patient with, after the loss of response, they measure their drug level. If they have a subtherapeutic drug level, mainly infliximab, if you do increase the dose, then you have 86% chance to recapture and either complete or partial response. And if you change the anti-TNF, then you have only 30% of recapture and either by complete or partial response. What about antibodies? If you have antibodies, presence of antibodies, then if you increase the dose, you have only 17% that you may recapture the patient. If you change the drug anti-TNF, then you have almost 92% to recapture your patient. This is a nice diagram explain how to approach your patient who loss of response and during maintenance. What you call a reactive approach. If you have adequate drug trough level, meaning that adalimumab is more than 4.5, infliximab more than 3.8, then you have a 90% specificity for failure if you did dose intensification or anti-TNF switch. And if you have a 75% if you chance to respond if you continue treatment or switch out of class. If you have antibody, then adalimumab more than 4 and infliximab more than 9, then you have a 90% specificity failure if you did dose intensification. This is the mechanism, possible mechanism of non-response to the anti-TNF. You have a different mechanism that can be explained. Mechanistic. Mechanistic means drug level is optimal, and you have none or low antibodies. The likely mechanism that explains target does not. The drug does not target inflammatory mediator. Then your reaction will be switch the class. If you have non-immune mediated pharmacokinetic, the drug will be suboptimal, and you have no antibody, meaning that there is rapid drug clearance or increased inflammation. And your response will be optimize the dose and possible add immunomodulator. If you have immune-mediated pharmacokinetic, the drug will be suboptimal and there is antibody. Drug neutralized by the antibody, anti-drug antibody, then you switch within the class. We have factors that affect the clearance of biologic, mainly presence of anti-drug antibodies, high baseline TNF, albumin level, low albumin level increase the clearance and worse the clinical outcome. Being obese, the poor responder. Being male, actually you have a poor good factor, bad prognostic factor. Proactive drug monitoring during maintenance. We have actually, there is no recommendation for proactive drug monitoring. Let's skip that. This is suggested drug trough level for during the maintenance. Adalimumab more than 5, and infliximab more than 5, adalimumab more than 7.5. There is a good correlation actually between the drug level and the mucosal healing. And this is proactive. I'll skip. Probably I will discuss this. This is a nice study, thorough study, looking for dose intensification during maintenance, which is proactive. And actually the outcome, the primary or outcome, there is no clinical or there is no significant if you do drug intensification during maintenance while the patient he has no flare. Again, this is taxes, the same. The taxes, what they did, they optimize the drugs and they randomize, change dose based on trough level or continue. There was no big difference in the primary endpoint. There was no difference in remission rate between the trough, between the two arms. What about the proactive drug monitoring after induction? This is a new thing really we are talking about. Actually, if you have a drug level more than at week 14, you have a highly chance to have persistent remission, almost 100%. This is a nice diagram explain how to approach during induction. So you evaluate your patient at between week 2 or 6. If you have adequate drug level, then there is no clinical response, then you change out of class. If there is clinical response, you continue, and then you at week 14, if there is antibodies or absence of antibodies, presence of antibodies, if there is presence of antibodies high, then you switch to another class or change to an anti-TNF. If there is low antibodies, then you escalate of medication. So take home message: one size does not fit all. Use clinical marker of disease severity to guide your initial therapy. Treat your target strategy using systemic assessment and approach, and monitor for disease drift. Primary and secondary non-response to anti-TNF can be common. Biologic check drug antibodies and check the drug and antibody. And when we should start using therapeutic drug monitoring: reactive, no initial response or loss of response; proactive as a part of routine clinical care. Thank you.